when we talk about advances in surgery, I always put these slides up. This is our pioneer surgeon, Matt German. At the time, they called Matt German. Essentially, he performed the first keyhole operation to remove the gallbladder for gallstones, which is a very common condition where people with gallstones, 1 in 8 people suffer from gallstones. In the past, we had to make a big cut to remove the gallbladder. It takes about 2 hours to do the operation, and a patient stay in hospital for 5 to 10 days. And then he performed the first keyhole operation to remove the gallbladder. And German Surgical Society at the time think he was mad, and then got rid of him from the registry. And a few years later, they realized everybody started doing keyhole operation, so they invited him back and gave him honored him as a result. So this only happened in the 80s. It's all happened in the 80s. I remember when I was a medical student in late 80s, early 90s, and everybody was talking about this operation, but not many people are doing it. But now you go to a hospital, this is a standard routine operation. If you don't do it, and people will ask you why you don't do it, because the benefit for patient is enormous simply by changing the way we operate on patients. So this is the same operation I did. Because the tumor is quite big, it's quite difficult. So I decided to do it with keyhole. So this is all done with keyhole, the same operation like that one, the one I just showed you the video, but with keyhole. So you can see the operative field is very centered to the point where you want to operate, where the tissue you want to take out. So the first thing we do, that's the liver retracted upwards. So this is tissue between liver and the duodenum. Again, this is the same device I used early on, but it's just longer. So I divide the bottom part of stomach in order to complete the operation, and then isolate the artery supplying the liver, blood supply is called hepatic artery, and then divide the arteries supplying the head of pancreas and duodenum called gastroduodenal artery. So it's all done under a direct vision with camera. So that's gastroduodenal artery that is giving off from the common hepatic artery from the liver, supplying the blood to duodenum and head of pancreas. So that's been divided. We use a lot of fancy instrument, and it's very expensive to do this operation. Of course, my girlfriend always gave me a hard time every time I do that, because my energy completely drained. So you need a high concentration for about 5 or 6 hours for this operation. You can't afford to make any mistake. If someone bleed, it's out of control. You have to abandon the keyhole operation and do it open like the first one. So the stomach is divided, and then the pancreas is then divided so finally the gallbladder is removed. So this is bit here in the back of the duodenum. To free the duodenum, we do call it cauterization to free a bit of peritoneum next to the duodenum on top of the inferior vena cava to actually complete mobilization. That means free the duodenum completely to finish the operation. So again, this is the same device I used for the first video called the ligature, and to divide that pancreas next to the vein called that vein here, superior-mesenteric vein. So you can see that blue structure there. That's the yellow bit is a big bit of pancreatic tissue, and then the vein there is called the portal vein, superior-mesenteric vein. And once the resection bit is done, then the reconstruction part starts. That takes another 2 to 3 hours. That's why it takes about 5-6 hours to do this operation. So I have to suture everything with the keyhole, like quite technically it's a bit more challenging, very difficult. So again, the pancreas is sutured onto the back wall of the stomach. So that bit there staple across the bottom part of the stomach. And then this bowel duct then sutured onto the loop of small bowel. We call it hepatobiliary. Once again was done with keyhole. Finally, stomach is joined onto a loop of small bowel to withdraw the continuity of the GI tract. So again, you can see it's done with suture laparoscopically. The advantage of this operation is, although it takes a long time for us to do, for open, I normally take me 3 to 4 hours to do for this operation keyhole, then I would double that length of time to do the operation, but recovery is much quicker without big cut in the abdomen. So essentially, end of the surgery, patient will have a 5 or 10 centimeter cut at the bottom part of the tummy. We call it Fanny Steele incision. Similar incision people use for cesarean section to take the tissue out, and then small cuts, 5 or 6 small cuts in the abdomen. So that's the major advantage of keyhole surgery. I'm lucky at Hammersmith. This is actually from Dr. Foster data. It's quite sensitive data. I don't want to publish it. So, so you can see at the Hammersmith Hospital, we have the lowest mortality rate for this type of operation. That means removing the major part of pancreas. What the GIST therapy in advanced disease, again, you probably can tell me more. So we all know that people may have a progression of disease after the Gleevec or chemotherapy stopped, and the progression can be limited and can be generalized. And generally speaking, all those patients we need to offer surgery. In the past, we offer surgery as a palliation. Okay, it's a palliative care because got metastatic GIST. But since has changed since the introduction of Gleevec, we offer cytoreductive surgery, especially after GIST treatment. People respond very well to downstage tumor in terms of size and number of tumor. And we find a window opportunity to offer surgery to give people the best benefit. We know from the data published from the route in America that both disease-free survival and overall survival are much better in patients who had combination of chemotherapy and surgery than surgery alone or chemotherapy alone. So I think prior to GIST, everything was palliative. I think this is quite important paper. You probably heard this already. So this is a very important paper comparing conventional chemotherapy with Gleevec. You can see dramatically disease-free survival, overall survival was much better. There's a blue line here. That's the graph there is doxorubicin, which was conventional chemotherapy prior to introduction of imatinib and Gleevec. So you can see the survival is excellent after the treatment with Gleevec. But why do we want to operate on patients and if they have had a good response to Gleevec? I think this is a reason why, because unfortunately some people do have relapse of disease on chemotherapy, or maybe they may not respond to chemotherapy as well as we hoped. It's very difficult currently to predict who will respond to chemotherapy before you started on chemotherapy. So it's very important to actually, I think the part of development at the moment is to try to identify markers which can tell us whether somebody will respond to chemotherapy or not, and individualize the treatment. And then you can see that 80% of patients, treated patients respond to chemotherapy, tumors still remain viable, and only less than 5% of cases where tumor completely disappeared on X-ray will have complete response. We call it complete response means if you take the scar tissue or you think where the tumor was after chemotherapy, have a look under microscope, you will not see any viable tumor cells. It's very few people will benefit with complete response to chemotherapy. And the other thing is the secondary resistance to drug after median 2 years of therapy. So this surgery is very important. I already touched on this. So people with stable disease on chemotherapy, we should definitely offer surgery. We know that long-term survival in terms of disease-free survival and overall survival are much better after surgery. And limited disease progression, once again, we should offer debulking procedure, try to reduce tumor load. And a lot of patients now, we actually look at the biology of the tumor itself, not only looking at the CT scan, measuring the size, we look at the biology of the tumor. For example, in a tumor where it has responded to chemotherapy, look at the structure of the tumor rather than size, a crude measurement of size, look at the biological activity using PET scan, and also look at the characteristic feature of the tumor itself. Some tumor before chemotherapy was very solid, after chemotherapy becomes cystic. So we think at the moment at Hammersmith, we think those solid tumors need further debulking and surgery, regardless how many they are. But if most tumors have responded to chemotherapy, become cystic after chemotherapy, so we target the treatment to those tumors which we think still contains viable tumor cells, i.e. they look solid on the CT scan. Of course, we offer surgery to those who are hot on the PET CT scan. So surgical options, metastatic GIST, there are 6 publications on this. If you look at R0, R1 resections after chemotherapy, we can still achieve that over 50% patients, because between 50 to 80% of patients, we can still achieve R0, R1 resection in patients with metastatic GIST after chemotherapy. And then prognosis is excellent, I would say. It's now I'm going to talk a little bit about liver metastasis from GIST, and liver is the common site for metastatic GIST, secondary to peritoneal disease. Although the rate is not high, but the liver is a common site to find liver metastasis, we tend to get a lot of referrals from various places where patients with metastatic GIST. And what I would say is we tend not to do major resection if we can get away with limited resection. That means debulking of the tumor rather than major liver resection of the tumor. The reason why we can't do that is based on the anatomy of the liver. Liver divided into 8 different segments based on this guy who is a Cunard, a French pathologist, and describes the liver, divided liver into left and right lobe of the liver due to from the embryological development of blood supply to the liver. So each segment has individual blood supply to itself. So there are 8 different segments. So we can target the tumor. For example, if tumor in segment 3, we can now just remove the segment 3 or do a tumorectomy by controlling blood vessel, reduce intraoperative blood loss, or do a limited resection, remove the 2 and 3 segment and leave rest of liver behind. Generally speaking, we can remove as much as 80% of liver volume because liver regenerates itself within 4 to 6 weeks. In human, liver will regenerate to about 12 to 20% liver volume. So if somebody has good quality of liver, haven't had too much chemotherapy, we can offer them major resection, depends on number of the tumor. Over the last few years, there have been lots of advances in liver surgery, all concentrated on transecting technique to divide the liver parenchyma. Because one of the problems with liver is, liver to me is a pool of blood with blood vessels, essentially. So it is a lot of blood in the liver. So try to reduce the intraoperative blood loss, which is key to success of liver surgery.